All right. There we go. So just a quick Zoom meeting reminders. We all are probably familiar with them at this point, but we'll go ahead anyway. Please mute your microphone when you're not speaking. It just makes it easier for everybody to hear. It's up to you if you want your camera on or not. We recognize this is lunchtime, so if it's best for you to eat some lunch and not engage right away, that's completely okay too. Also, please rename yourself to include your pronouns if you are comfortable. And whenever you are open and able to, please put questions and comments in the chat, or at the end if you'd like to unmute and ask questions verbally, that is also all good as well. And before we get started, we're going to read our ancestral land statement from MPHA. We ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a long-standing history and connection to the land since time immemorial and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and US governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors and descendants, as well as the land itself. Perfect. All right, so I'm going to keep letting folks in. I'm also going to stop sharing and go ahead, our lovely speakers, take it away.
Thanks, Chloe.
Yeah, welcome everyone. All right. All right. Touchstone Mental Health, we're located in the Twin Cities. And I'm the executive director. I've had the privilege of being here for the last 7 years. Nicole?
Hi all, I'm Nicole Rudisill. I use she, her pronouns. I'm the director of development and communications, although quite frankly, sometimes I say I'm the development and communications director, sometimes the communications and development director, and also jumble. But I've been here since late April, so you'll mostly hear from Ellie today, and I'll chime in as I am able. But I'm excited to see who all is here so far in our chat as well. Great to see a bunch of people from St. Paul since we are expanding out there sometime soon.
Great. So I'd like to thank the Minnesota Public Health Association and all the important work that you do in public health. We really consider you partners, especially during the pandemic. We realized how much we rely on public health to help us get through each and every day. And I know that was a tough time for many of you, so I appreciate all of the work you did to help us safely get through. Our mission at Touchstone, we've been around for about 41 years. We were started by the U of M group of social workers and the recently retired Dean of Social Work, Dr. Jean Quam. She was one of our original 5 founders. So Touchstone provides innovative person-centered services that foster hope, health, and well-being. Our programs connect people with community services, resources, and healthcare, and we provide ongoing support so they can thrive in the community. We really do look at the dimensions of health and really look at how do we help people with holistic wellness. And so we fulfill our mission providing services that improve mental health and housing stability, reduces homelessness, and increases self-sufficiency for the people we serve. More and more we focused on providing housing because without housing, it's really hard to build on a foundation of health. And the more that we kind of increase our services in the housing field, the more partners have come to ask us to partner with them. There's, as you know, we continue to have issues with people experiencing homelessness and being unhoused in our community. And oftentimes it is related to having a diagnosis of a mental health or substance use disorder. And our low barrier housing that we work with to provide supportive services really has been effective for helping people find and keep housing. And certainly we help people be rehoused. So if we work with people and they lose their housing, we help them find new housing and try and figure out like, what was it last time that wasn't effective? How do we help change the intervention so they can be successful the next time we help them find housing? So I'm going to start with a little story about one of our programs at Minnehaha Commons, which is a program that works with adults that are 55 and older, and everybody who lives at Minnehaha Commons has their own efficiency apartment, and they have all experienced homelessness.
My name is Mary. I was homeless and going through different things in life. There was good times and bad times. Things that happened to me that gave me a disability. Um, I was diagnosed at 23 as postpartum depression, and from there it seemed like everything would go downhill. I knew something was wrong with me, so I decided to adopt my kids out, and then I sought help, and then from help, I've been raped in shelters, which put a fear in me, and I don't trust shelters anymore. The other places that I stayed at, they didn't listen to me, and it always felt like, I was being passed over, and I was always stressed out, had suicidal tendencies, I would always think about, well, if I do it today, ain't nobody gonna care about me, they'll get over it and stuff. Here, they care about me. The people here is not gonna let nothing happen to me. They're not gonna let nothing stress me out to where that thought can come true. It's not gonna come true because I know for a fact they care about me. They don't want nothing bad to happen. It's peaceful here, and I'm proud of being in here because I see all the work and stuff that I did. This is my peace, my quiet, it's my joy. Touchstone has gave me my life back. It has gave me a life that I didn't ever think that I would ever have, Being abused, beat up, negative, the stuff that happened to me always made me feel that I was worthless. Here, I'm somebody. I'm somebody happy. I'm a success story with Yumi. I want to be another success story and show other people, hey, we can do this regardless. People are already labeling us as crazy and stuff. I might be crazy, but I'm positive. I see a brighter side to my disability, and I need people that really care about people that have a disability to see this. I want everyone that's in this building to work on their goals, ask for help, feel like I feel. I'm happy to be here. I am so proud that I finally found a place that cares about me and is willing to go out their way to make sure that I have my goals met. That's why I love it here. This is my home, and I'm not going nowhere. And I want other people to feel this way. I really do.
All right. And Mary really is a leader in her community at Minnehaha Commons. She will check on other tenants. Sorry. Let's see, get my page down. There we go. So we have Mary lives in one of our community housing programs. So we have 3 programs: Rising Cedar, New Hope Apartments, and Minnehaha Commons. We partner with supportive landlords, affordable landlords. Minnehaha Commons is owned by Alliance Housing, so all of the tenants there have a lease with Alliance Housing. Our programs at Rising Cedar and New Hope Apartments, the affordable landlord there is PPL, Project for Pride in Living. So we really follow the tenets of permanent supportive housing, where we advocate on behalf of the tenants. They have a separate lease, so if there's an issue with rent payment or with a lease violation, we can really be an ally to the client to help keep them housed. We provide nursing, counseling, groups. Minnehaha Commons is newer in terms of we don't require anyone to say or have a mental illness to move in. You don't have to receive services from Touchstone. And so we were piloting a model where we really wanted it to be low barrier to entry so that people can come. We build trust. A lot of people who have experienced homelessness have a lot of trauma. and don't want to like sign up for services or a program. What they want is housing. Once they get housed, we work to build trust, and we're there to provide services as they need them. So for some people at Minnehaha Commons, we hold their medications. The nurse will dispense those as needed throughout the day. Everybody there also has their own stove, and we don't have meal service. At Rising Cedar and New Hope Apartments, we have commercial kitchen and we have meal service. And there's certainly pros and cons to both of that. I know a lot of our tenants at Rising Cedar love the fact that they don't have to cook. So we're trying to have a variety of housing for kind of what people's needs are. Nicole mentioned we're coming into St. Paul, and we're doing a new partnership with Aon Housing. Aon recently is going through the process of purchasing the old Dorothy Day building, which is called Mary Hall. It had been a homeless shelter during COVID, and now they're going to renovate it into 88 apartments. And there's a number of Section 8 subsidies that are going to be associated with that building. And we will be on site 24/7 there as well to provide support. So that won't be opening till 2025 because they have some intensive remodeling to do of all the units to make it a really nice apartments. So hopefully that remodel will be starting early next year and take about 18 months. The other area we provide services is called Intensive Residential Treatment Services, and the horrible acronym there is IRTS. We have 3 of those in Bloomington, Minneapolis, and in Anoka County and Fridley. Those are programs where people can stay with us up to 90 days. Typically, people are exiting inpatient hospital stays and really just still have a lot of symptoms in terms of not ready to go back home. We also have telepsychiatry there as well. We have counseling groups, really help people kind of set some schedules and goals for where they want to move next. A lot of times when people go to residential treatment, they don't have a place to go. And so we spend a lot of their 90 days with us working to find a place to live next. Community health, community mental health is all of the services we do in the community. Case management, housing innovations, care coordination, really working with people in their own apartments, helping people find and keep housing, working on goals. Some of those services, case management is pretty low intensity, checking in with people monthly, seeing them quarterly, face-to-face. Housing innovation, we may see people much more frequently. The majority of our services are paid through Medicaid. So 99% of the people we work with are low income, under the poverty level, usually on Social Security disability, although a lot of times people, especially folks we're working with to get housing, may have lost benefits and be uninsured, and we work with them to get back on insurance. And so Medicaid, often it's through a prepaid medical assistance plan like a Blue Plus or a UCare. So most of the services we provide are a fee-for-service type arrangement, although we do a lot of grant funded programs as well. So last year in 2022, you can see we served the majority of our people in the community, in community mental health, and our target case management, Touchstone Connections, care coordination. And then in our community housing programs, we served 266 people. And one of the things I'm really proud of is the length of stay, how long people stay in our housing. So New Hope Apartment is our oldest program that we've had the longest, and we have a couple people who have lived there 18, 19 years. Rising Cedar is just about to have our 10-year anniversary, and 22% of the people in this build, I work next to Rising Cedar, next to us here, have been here since we opened 10 years ago. So we don't, it's permanent supportive housing. Sometimes people move because they need a higher level of care. Sometimes people move because they've progressed in their recovery and they don't need this level of support. We've had even a woman graduate from grad school while she was here and then move on into her own apartment. So it kind of really depends. People are in all different places on the recovery journey. Over half the people we work with have both a co-occurring with both a mental health diagnosis and a substance use disorder. And then our residential treatment, since people stay about 90 days, and each one of those is no more than 16 people. I was just talking about this yesterday. The reason all of the residential treatment programs in town are 16 or less is because of a federal rule that doesn't allow you to take Medicaid funding if you have more than 16 people. And so that was a move on the federal government to kind of ensure that there wasn't institutional marginalization when they went through that phase in the late 80s, early 90s, but it's actually caused some unintended consequences to set kind of an arbitrary number of 16 for residential treatment. So what kind of staff do we have at Touchstone? We have mental health professionals, LICSWs, licensed psychologists, LMFTs, LPCCs. Those folks do diagnostic assessments, sign off on treatment plans, do a lot of clinical consultation. We have 240 staff, and we have about 20 mental health professionals. We have a lot of people that are in the practitioner level role. To be a practitioner in Minnesota, you can either have your bachelor's degree and 1 year experience in the field, or you can work 3 years in the field and 6,000 hours of experience, which is a nice pathway to get into the field without needing a bachelor's degree, and one that we're working with partners on, really trying to figure out the pipeline. One of the things we've experienced is a shortage of staffing, and so we're trying to reach out and figure out how do we get people to know about the mental health careers, let them know that there's jobs available even without a bachelor's degree, and how do we help people get to that pathway. So we have these entry-level roles called peer professionals, that's people with lived experience, rehab workers, and mental health assistants. If you work for us for 3 years as a mental health assistant, then you have enough hours to qualify as a mental health practitioner, and that's a nice stepping stone into the workforce. We have nurses, we have a fitness specialist, and we have a health coach. We're trying to always expand those roles. Oftentimes that's done through grant funding because it's harder to find funding for those roles. We also do tobacco treatment, and we've really made a push to have tobacco-free grounds, and that's often still been a challenge, but people with mental illness smoke at a much higher rate than the general population. A lot of that is because of marketing to folks, and also because the mental health community for many years really built a lot of systems around that enabled smoking. So we're really trying to ensure that people have access to nicotine replacement therapy, tobacco cessation support, and that's been a real focus of us the last few years. And we have admin, accounting staff, communications and development, and then we're a 501c3 nonprofit, and so we have a board of volunteer directors, and they have a whole variety of roles. From there maybe have lived experience with mental health themselves, they may be a banker, an attorney, a family member, they might have an adult child with a mental illness. A lot of different people have different reasons to be engaged in the work. And so we have 17 members on the board right now, and they do a good job with providing advocacy, supporting our work, helping us fundraise, helping set strategic direction. And our strategic plan, really 3 main goal areas. We always are looking to improve and increase our advocacy, to improve the services, make sure services are sustainable. We love to mentor and help new organizations that are providing mental health services. Our talent, as I mentioned before, workforce challenges we've had over the past few years, we really want to foster a healthy organizational culture that attracts and retains a talented, passionate, and culturally competent workforce. And then we want to promote and sustain a financially sound, mission-driven organization. As I sometimes say, no mission, no money, no mission. So we need the funds and the support we need to be able to fulfill our important mission in the community. We've grown quite a bit. There's always so much need. And in 2010, we were a $4 million organization. And in 2023, we'll be very close to 18 million. So part of managing growth and change has just been to keep up with our infrastructure and making sure that we're taking advantage of opportunities that are put out there that will improve the number of services that are available for people. Lots of long waiting lists on our housing programs, and we'd really like to make sure that people aren't waiting for years before they get access to safe, affordable housing. It's really important that we create a culture of belonging at Touchstone. We believe that mental illness requires a focus on whole person wellness, and we recognize that racism and other forms of oppression impact the lives of the people we serve. And so equity and inclusion are central to our mission, and we certainly are impacted by structural racism, and work to both educate ourselves, provide tools for staff, look at policies and procedures. How do we break down the systemic racism of both the system that we're within and within Touchstone? Ongoing work that we have to do, absolutely. Some of our outcomes for last year, 82% of people in community mental health and housing services made progress on at least one goal. 76% of anyone who entered our residential treatment program was successfully completed it. And we do a lot of focus groups, surveys. We always want to get as much input from the people we're serving as possible. And 81% people said that we met their needs well last year. And we actually have a pretty decent survey turnout. I think it's because we've done it so much and people are used to it, but I'm always impressed how many people actually fill out the surveys that we provide. 79% of the people that were unhoused and moved into Minnehaha Commons retained their housing for 12 months. 81% of people in housing innovation have retained their apartments for 12 months. And as I said before, if someone loses their apartment, we work right away to make sure that we find them a new place. 83% of individuals in community mental health services did not have a medical or psychiatric hospitalization. So we work hard to make sure that people have a primary care provider and that they're doing as much preventative care as possible to avoid unnecessary ER visits, because it's not a great place to get care. I don't know, Nicole, do you want to pop in on this one? Or maybe
Sorry, I recognize you couldn't hear me. I was like so excited. One of the things I wanted to make sure that we covered was really thinking about how does Touchstone fit into the world of public health. From everything that Ellie said, I think it's pretty obvious, but I wanted to make sure that we kind of called it out to attention, right? Touchstone is really a nonprofit organization that's providing community-based mental health services for adults in the Twin Cities. Public health, as you all obviously know, science of protecting and improving the health of people in their communities. And where I think Touchstone fits best within that world of public health is that each year we're helping over 1,500 people regain their confidence, embrace their self-worth, like you heard Mary talk about in the video earlier, and really find a sense of belonging and hope for their future. And so really what we work on is not just about the individual, but really about making the lives of everyone around them improved as well.
Great, thank you. Appreciate that. All right. Some of our challenges in 2022, reimbursement rates, since we primarily work with Medicaid and the fee-for-service model, doesn't really keep up with the wages. So we were at the legislature this year and we did get a few of our rates increased with both inflationary adjustments being added and some actual just rate increases that will happen in early 2024. Also, being caught up in this model of it's a fee for service, so we have to deliver the service to provide it. If we have folks in the community, especially if we know folks that are unhoused, sometimes when we're looking for people, trying to track people down, or if people no-show, that's a lot of work and outreach we do that there's no reimbursement attached to it. And that it's still very valuable work. And that's what I often talk about why we need to fundraise, is that you don't want to only have it be transactional. So if you don't meet me every single time, I'm not going to be able to provide you the service. That really, people fall through the cracks that way, and the way that that's set up. So that's where we really look for grant and donor dollars to help, folks that might be harder to engage, maybe experiencing challenges and won't be able, or if they do meet you, really have a low tolerance for the amount of time that they can interact. Some of our rates, we have to bill even in 15-minute increments. And so it's just a little, it's challenging sometimes to work with everybody's needs within that fee-for-service model. Unfortunately, we have seen a number of overdose deaths related to fentanyl and we have Narcan available. Staff turnover is another challenge, recruiting new staff for open positions. As I mentioned before, working within systems of systemic racism in the aftermath of the community trauma from the murder of George Floyd still impacts us every day. To get crisis in Hennepin County, we can call COPE, which is, they're available 24/7, but they're often inundated and aren't able to get to help us with a crisis situation in a timely manner. Minneapolis has a behavioral crisis response unit now, but we can only access it through calling 911. And there's still a high reticence around calling 911 for behavioral health crisis. So in Hennepin County and in city of Minneapolis, we have a couple options. In Anoka County, there's a mobile crisis team that we can access. And we're looking forward to developing some partnerships in Ramsey County around how do we access crisis services when we move into the St. Paul. So as I mentioned, we have Narcan. It also means our site in the Seward neighborhood is what's called a naloxone access point. So anybody off the street can walk in to during our office hours, and we'll give them both fentanyl test strips, or it's an injectable form of naloxone. You can do a quick YouTube training video on it. And we, especially the fentanyl test strips, we're really encouraging anyone that's using to not use alone. If you are going to use alone, to make sure that you are testing your drugs to ensure that there's no fentanyl. Or if you know there's fentanyl, then absolutely don't use alone. So really using some harm reduction strategies to try and keep people safe. So we're working hard to mirror the people we serve. Out of the 1428 we served last year, 49% identified as white, 42% as BIPOC, and 9% we didn't have their race collected. And our current staff is 41% BIPOC and 59% white, and our board is 61% white and 39% BIPOC. So we have some work to do to make sure that we mirror the staff, the clients that we serve, and we have some strategies around how we're continuing to diversify both our board and our workforce. And I think it's important for us to keep these numbers public. It's in our annual report to hold us accountable and to set goals that we then reach. We also look at outcomes by race, and we do that to make sure that if there's any interventions that we can provide, to look at, are there issues of people being discharged based on bias, and how do we address that? The interesting thing is last year we had more white people complete treatment than BIPOC individuals, and this year that's flipped, and we made a conscientious effort to really work on ensuring that, if there is incidences of bias related to past discharges, that we really look at what are things that are getting in the way, what kind of training can we provide to make sure that everyone has equal access to tools for recovery. So this year, I'm happy to report that more BIPOC people actually successfully completed our residential treatment than white people. And if you look at the end, 59 of 89 versus 91 of 144, you can kind of see what the numbers are. We still have some work to do around housing innovation. So 76 people who are 76% of BIPOC individuals in housing innovation retain their housing for 12 months. And the rate of the white clients was 85%. So one thing we do is we look at the reasons people lost housing. We look at what other interventions or strategies we can provide. Is there services that would be helpful to provide to help people from losing their housing? So those are why we also find it important to look at outcomes by race. So health equity at Touchstone, I talked about this a little bit, but we are always looking to make sure everyone has access. So one thing we heard last year is that people with low English proficiency were really struggling to get admitted to residential treatment programs. So we did apply to a grant with the state of Minnesota. And so we're piloting one of our residential treatment programs to do all of the intake paperwork and client materials and signage in 4 languages: Spanish, Karen, Hmong, and Somali. And so that will be at our Lyric Lane program. We're working with Google Translate, with the language line, with in-person interpreters, figuring out what how does staff work with these different resources? How do clients make connections with each other? And so we're going to pilot that and hopefully learn a lot of lessons to then be able to expand that to all 3 of our residential treatment programs and expand some of that also into our community housing. Health equity looks like, doesn't matter what your language is, you'll be able to access services at Touchstone. We're also looking at partnerships with other community organizations that work with, that are culturally specific to see that how do we support each other and how do we ensure that resources that they need that we can either provide directly or through collaboration. For staff, we have affinity groups as a way to help people have the belonging in their community and at their workplace at Touchstone. So we have 5 affinity groups, and those are groups that staff can attend, do community activities. Sometimes they do special activities for all staff, help promote events in the community. So we have a recovery group, African American group, LGBTQIA group, Asian affinity group, and American Indian affinity group. Staff wellness is important. One of our biggest challenges is staff burnout. And so we have an employee assistance program. We'll call them out for critical incidences, and they've actually been really good. So if we've had say we have a resident die of a fentanyl overdose, the employee assistance program will come out on site the very next day, do critical debriefing, meet with staff one-on-one. We'll make sure we're having grief groups available for both our tenants and our staff, really making sure that people can deal with any trauma that they've experienced in the workforce and the workplace. And then we really encourage people to use, either the app or the employee assistance program to get free confidential support. I've mentioned a couple times why we do fundraising and why it's important. And so we do just one event currently per year that Touchstone puts on, and we're having one coming up September 14th at the Metropolitan Ballroom. So certainly if you're interested in that, we'd love to have you come. It's a free 1-hour breakfast, and it does have a fundraising ask at the end, and you learn more about Touchstone. Like last year, we showed that video about Mary, and Mary came to the event and was very excited, stood up and talked to a number of our folks that came. She was excited to share her story. Other ways you can get involved, we have job openings, and then you certainly can send an email to Nicole or I if you have any questions or follow-up, or you want to just learn more about Touchstone or something piqued your interest that we talked about today. We also do work with interns, usually master's level for social work or counseling, but we certainly work with nurses, and we've had PharmD and all different types of interns in the past. All right, appreciate you letting me share about Touchstone today, and I'll see if you have any questions.
All righty, well, thank you very much for that wonderful presentation. It's really exciting to know that Touchstone is making such a difference in the community, and some of those outcomes are really exciting. So really thank you for that presentation. If anybody has questions, I know Gina was asking for the different languages that you provide, the 4 of them, and to type them in the chat. So that's definitely the first question. To get us started, I have a million questions, but if there's anybody who wants to go ahead and start, please feel free to unmute or put a question in the chat. And if there are no questions, I can certainly start in mine. All righty, well then I will start. So I know that you work in the Twin Cities, you work in different cities and different counties. So I'm just wondering, do the different counties and cities you work in differ in how you have different operations, and how so?
Yeah, I would say the majority of our services are in Hennepin County. We have a contract with Anoka County for our residential treatment program, and then we do case management in Dakota County. And so we kind of look at opportunities as they arise and see what's needed. The supportive housing program that we'll be opening with Aon is in downtown St. Paul. So we're actually very excited to branch in the Ramsey County. But this will be our first program, besides occasionally having maybe a target case management or care coordination client move into Ramsey County, and then we continue to work with them, but we haven't really had a significant presence. I think it's more of like, oftentimes it's organizations either saying to us, would you be interested in applying for this? Or we're looking for a new provider. Would you be interested in coming to this county? So we certainly don't have any reasons not to expand besides, staffing capacity. In 2023, it's been easier to hire staff. So I think 2022 for some reason was the worst year for staffing, but 2023 has been a little bit easier.
That's awesome. Yeah. And somebody messaged me, what work are you doing to work with any organizations outside of the metro area, up north and south?
Yeah. Yeah, the biggest thing is we're part of a group called MHPAM, Mental Health Providers Association of Minnesota. And so a number of those members, I'm actually the president this year of that association, and we have members that are all over the state. And so we share resources, we legislate together. We're all part of the Mental Health Legislative Network with NAMI, and we all go in on bills together. And so that's really the best place where we support folks in outstate Minnesota. And we've occasionally taken a meeting with someone in another county when they're either wondering how we fund a program or want some technical assistance, or if, we've considered moving to different counties up north, but typically there has been a provider already in the area that if they just need to know how we're doing something, and that we haven't had to actually move that far out. But I feel like there's so much work to be done in the mental health field. There's no reason for us to have any state secrets. Whatever we're doing, we're happy to share and help you build a sustainable model to make sure that these services are available across the state.
And in that same vein, we are also part of the Minnesota Council of Nonprofits. And so usually someone from our executive leadership team is attending the conferences or the webinars so that we can also be doing that on the ground sharing work, not just with other mental health providing organizations, but other nonprofits throughout the state.
Excellent. Can you speak to the labor shortage and, the contributors to burnout in the field and what measures have been changing and the impacts that have been made from it?
Yeah, I would say the biggest problem biggest problem is pay. So, we get reimbursed for Medicaid. And so, what we are able to pay a case manager is, what any other nonprofit will pay. And, where all of our salaries are pretty similar with case management. But if you go and get a county job, you could make $15,000 more a year. And I can, so after someone's been here 2 years and they get a job and get a $10,000, $15,000 increase, I just say, well, good for you. I absolutely wish I could pay you that. And, I've had county people say, we love getting people from Touchstone. You train them so well. And I go, oh, well, thanks. The other interesting thing is a lot of people do move out of state. I would say about 20% of the staff that we lost last year moved out of state for family, education, another opportunity. I think we work with a lot of people kind of right out of college or right out of grad school. And it's just a time in your life where you're kind of seeing what your opportunities are. So that's also one reason we have turnover. So yeah, we're always looking at our turnover data, trying to be what can we do? Why are people leaving? 20% going out of state, 25% getting a significant pay increase. So I think right in the middle is where we try and figure out, sometimes people say, well, I didn't see any opportunity for growth. So then we say, okay, how do we get the message out there that, if you'd like to grow your career, let us know. And there's also, I think we've done a better job of helping people move within the organization to make sure people see that there is a trajectory at Touchstone where you can grow your career.
I also want to say, Chloe, because you asked about burnout. And I think, so Ellie mentioned I'm pretty new to Touchstone, but I think regardless of that, it's fairly easy to speak to. Burnout at pretty much every level of our organization comes down to a lot of people with really big hearts who care a whole lot, who get burned out because they care a whole lot, right? And I think whenever we can, in general, Touchstone, I think, does a really good job. We have a pretty good culture of encouraging people to take care of themselves and really take time off. We have like very generous PTO and vacation policies so that people really do have the flexibility to say, like, I need a day, right? Like I need a break. And I think that's a huge benefit to the culture here at Touchstone. But I also think that at the end of the day, this work is just tough. It just is, and there's only so much you can self-care your way out of that, right?
Yeah, I think we have self-care plans, and we do trainings on compassion fatigue, helping people, understand. And we often talk about how it's so important to make sure that we ourselves are in therapy, that, making sure that we're taking care of ourselves, our own mental health, prioritizing that. So taking the stigma out of, like, of course, if you're working in the mental health field, take advantage of receiving mental health services yourself to make sure that you're healthy every day. So, oftentimes I'll check in with people about their self-care plan, and they'll say, I've been too busy to work on my self-care plan. Like, well, okay, well, let's strategize about how you can make a little more time to work on your self-care plan.
That is a story as old as time, absolutely. And I know that there are definitely other sectors of public health that experience, similar things. We do so much care, and we don't necessarily care as much for ourselves as we need. So I appreciate that. I think that's a really important thing to have your employer supporting and encouraging that care and receiving that. That's really wonderful. I have one more question, and if anybody else does, please go ahead. I remember you mentioning that one of the housing complexes that you recently removed the mental health diagnosis to make it, to remove that barrier so folks could live in there without that diagnosis. How has that really impacted who and how you support and your services in that way? And would you consider, removing that diagnosis in other ways? And how has that been changing your processes, I guess? Yeah.
Yeah, so it's interesting. Our first two programs, New Hope and Rising Cedar, we based it on people that receive what's called a waiver. So they're on a CADI waiver or elderly waiver, and receive it through a service called Customized Living. So it's 24/7 support. And so when we decided to build Minnehaha Commons, that having a waiver before you can move in really doesn't necessarily work with people experiencing homelessness. So you have to be on insurance, you have to have the public health person review, give you, qualify you for the level of care of a waiver. So we basically said, all you have to be is low income, over 55 and experiencing homelessness. You don't have to say you're going to work with Touchstone, you don't have to get, and we also can provide customized living there as well for people who need that level of support. What I'll say from an administrative level is that program has yet to break even. What I'll say from a human level is we have been able to get people in right away and work with them to get them on insurance, to get them the support they need. And that can often take a long time to build that. So I feel like the model's right. We just have to figure out how we fund it, because that gap between, and there are people, receive fewer services at Minnehaha Commons. It takes them longer to receive the services. And the outcomes still have been pretty good there in terms of working with folks. So I think so we're still trying to figure out what's the magic way to make it work. We want it to be easiest for people to get in, and removing needing to be on a waiver absolutely did that. So I don't know if that completely answers your question, but we're still working our way through maximum access, being able to provide people the level of service they need when they need it without having extra bureaucratic things to jump through. And we have gotten a ton of foundation support at Minnehaha Commons as we've gone out and pitched this story to say, this is what we're trying to do and what we want to try to see how it works. And it resonates with folks. And we can give you, data about when they moved in, they were on general assistance. We got them on Social Security. We were able to get them on a waiver. Now, 18 months after they've been with us, they have all of this things set up in place. But probably about a year of that, we didn't have really a mechanism to bill for services. So I think trying to figure it out exactly is where we're at.
Wonderful. I see there was a question in the chat, and it looks like it was answered, unless, did you want to expand on it at all, Ramo? Or there's somebody else who, oh, perfect.
Actually, I would love to have Ellie expand a little bit on the answer that I offered, because I just offered the very general. We primarily work in Hennepin, Anoka, and Dakota counties. But Ellie, Ramos specifically asking about case management services, and are those exclusive to the Twin Cities, or is that also broader and within all 3 counties that we work in?
Yeah, so targeted case management, we provide in Hennepin County and Dakota County.
Perfect. All right. Well, if there are any other remaining questions, I believe that we offered the emails in the chat. Would you two be able to put those in the chat one more time, or it was on the presentation as we are wrapping up? Because I know a couple of folks messaged me about wanting to connect with you both. So while we do that, I will just finish off with our MPHA duties, and then we will say goodbye for the day. So with MPHA, as always, we have a lot of wonderful opportunities for folks to be connected. We have different committees. We have the Policy and Advocacy Committee, the Health Equity Committee, and then the Membership and Communications Committee. We have new co-chair openings since I am leaving and my co-chair has also left. So if you want to get involved that way, that's really great. We also have an operations intern position for folks looking for part-time employment. All of these you can find them at mpha.net. And while you're there, if you're interested in staying connected in a bigger way, please become a member. There's a lot of really great opportunities to become a member and meet some professional and personal goals as well, being a part of this organization. So please feel free to reach out if you want to learn more about that. You can check out all this information out on mpha.net and follow us on all of our social media platforms you see below at mHealth Public Health. We are always promoting all the stuff we do because we want folks to engage with us. So that is all for today. Thank you all for your time today, and thank you for this presentation, and have a great rest of your day.
Thank you again.
Thank you.